My name is Sue Lareaux. I'm at the University of Colorado in Aurora, Colorado. And I'm going to be talking about pulmonary rehabilitation in underserved areas. And I have no financial disclosures. A common theme, whether it's COPD or coal miners' pneumoconiosis, and the reason pulmonary rehabilitation is effective is that they develop a respiratory impairment, and then the person gets a shorter breath, dyspnea being the term, with moderate activities. So they begin to give up activities, like a person might stop mowing their lawn and hire someone. And then they get physically deconditioned because that might have been a primary form of activity for them. And so they recalculate or calibrate in their body's mind, and they get shorter breath with even less severe activities. So they give up maybe cooking or making the bed. They get somebody to clean the house. And then they further abstain from activity because it's a natural sensation. You get shorter breath. You want to avoid the activity because it seems natural. But in fact, it's not. Although it's natural, it's not physiologically helpful because this deconditioning cycle makes a person so out of condition that they get breathless with even the most minor activity. And this is where pulmonary rehabilitation comes in. And the one thing we like to stress to the patient is shortness of breath is not hurting your lungs. It's not like walking on a broken leg where you can further stress a fracture. So to get them comfortable with that is to some degree helpful in getting to realize that activity can be overcome. So what I'd like to talk to you today about is give you a little tour of pulmonary rehabilitation, typical program. Rehabilitation typically occurred in COPD patients, but we're seeing it in other patients as well, although earlier it was done in cystic fibrosis patients, asthma patients, tuberculosis, but we now have interstitial lung disease and pulmonary hypertension patients in which we're providing rehabilitation. A very little bit about financial coverage and my final thoughts. So this is the definition we developed in the American Thoracic Society jointly with the European Respiratory Society, that to stress that it's a comprehensive intervention. It's not necessarily a one-on-one exclusively. It requires collaboration with other people, which I'll talk about. And we've tried to emphasize it requires a thorough patient assessment because all too often we would get patients referred to our rehab setting in which a diagnosis was not clearly made. For example, a patient might have pure heart failure. They were short of breath, just like a COPD patient, and we'd start providing rehabilitation, and somewhere along the line we found that it wasn't COPD at all that we were rehabbing for. So we tried to emphasize the thorough patient assessment, followed by assessing a patient to tailor the activities. And these are the core components of rehabilitation: exercise training, education, and behavior change. And the fact that it's designed to help the physical and psychological condition of people with chronic respiratory conditions. Now, here are the team members. And generally there is required a medical director, a physician, a program director who could be a nurse, a respiratory therapist, or a physical therapist. Those are the three more likely groups, although occupational therapists could be the program coordinator. And the team members vary as to which team members come in, depending on what your resources are in the community. And we'll talk about this because obviously in a rural community, you might not have all of these resources available to you. And I made a note here that a physician is required if you're getting Medicare reimbursement, and many insurance companies are following Medicare reimbursement guidelines in which a plan of care has to be written and developed for each patient. And there has to be a program coordinator identified. And so depending on whether this is financially dependent on Medicare versus local, it would vary on the to be clear on what team members you need. So here's a typical setting where pulmonary rehabilitation, we say it could be outpatient or inpatient, but usually they're hospital-based. In other words, patients come to the hospital and there's a room in the hospital where we exercise them. programs usually could run 4 weeks, depending on the design. That would require very intense, frequent observation, or preferably 6 to 8 weeks, somewhere in that neighborhood. It takes about that long to get patients reconditioned, comfortable with themselves, more self-confident. 4 weeks to me is a stretch. Now, the advantage of the inpatient where patients is that you have all disciplines available, obviously, because you're in a hospital. And so we say it's for complex patients, patients requiring supervision. And then if they've just been discharged from the intensive care unit or post-exacerbation of COPD, which is what the ECOPD stands for, which is a recurrent worsening of disease, and then they get better, they get treatment, maybe antibiotics, prednisone, and now more commonly it's shown that pulmonary rehabilitation will help patients recover from exacerbations. So the inpatient area is reserved for the more complex, and although outpatient, this is where I'd have mine, outpatient, but it was in a hospital setting. I've run a 6-week program in length and an 8-week program in length. When you're doing the 6-week program in length, you want to make sure patients have a program, a home program once a week to take over, because you really need about 3 days a week of training for patients to get really into rehab. So typical program design, 2 to 3 days a week. Usually you start out with a goal of 1 hour of progressive exercise, which I'll talk about because it's not simply treadmill, and about 60 minutes or an hour of education a week. And then the behavioral change, this is a little bit harder to identify in rehabilitation because, you've got other patients in helping motivate the patient. They learn different things, so it's not easy to tease out as saying I'm exercising you on a treadmill for X amount of time at a certain amount of power, and this is what you did. You improved from this to that. The behavior change, as you well know, it's meeting you in the clinic or even in the grocery store saying, look like you're having trouble, maybe you should go see your doctor, or things like that. Those are like the intangibles. It's a little bit hard to measure, and we, even though we measure a lot of outcomes in pulmonary rehabilitation, that has been our weakest link in really trying to identify that. Now, what kind of exercises am I talking about? We're usually talking about upper extremities, arms, lower extremity, legs. We know a lot more about the leg exercises because physiotherapists around the world study it to kazoo. Extremity, upper extremity training, a little bit more difficult to measure a difference in what patients do with upper extremity because it's harder to translate that into everyday activities. Usually you use your lower extremity strength first. But what do? Well, first of all, you want to develop strength so they're stronger. So this might be a combination of hand weights, arm lifts with or without, depending on how deconditioned the person is, or the TheraBand, the elastic resistance, develop strength. Lower extremity strength are ankle weights, machine weights, and also TheraBand use. The endurance training, that's to go for the long haul. So good to get them strong. The next step is to get them to go longer. And so endurance training, arm ergometry, dowel lifts, or rowing can be used for endurance. And treadmill, the motorized. I just want to make a point of this. The kind that you motorize yourself, and I can't remember what it's called, but you have to generate the energy to get the wheels going, is not very useful because patients take up so much more energy moving those kinds of devices. So we emphasize the motorized treadmill, or it could be training down a stationary bicycle, or it could be simply walking a certain path as your endurance exercise. And then stair climbing could be added to it to develop some balance issues, and then, of course, promote what their home environment is. If they live on a second-floor flat or a second-story house where the bedroom is, then you want to train them so that they can do that more comfortably, and we have ways of teaching pace breathing to accomplish that I'll mention briefly. So here's the upper extremity resistance. This is moving the arms against resistance, and you might increase the degree of resistance over the 6 weeks, say, and then lower extremity resistance of various kinds. And then for endurance, this is an arm ergometer, sits on a table. Patient has maybe no resistance to start out with. We'd have them go for 30 minutes, add a little bit more resistance, make that goal 30 minutes. Or the treadmill or the bicycle. Same principle. You have them walk. I hope that's not my phone. Have them walk for 30 minutes without resistance, or they'll usually say, I could stand a little faster speed, or I could stand a little higher incline. But the goal is 30 minutes of nonstop exercise, and there are some cases where we do what's called interval training, and that is they can take short bursts of exercise, but then they have to rest. So there's any combination of exercise types we can do. Now, educational topics are going to depend on your group. If you've got patients with coal miner's disease, obviously you're going to focus on that and probably COPD, as opposed to if you have a primarily interstitial lung disease clinic, you would talk more about those. But these are generally the topics. What are the lungs like? And a little bit of, we think these are helpful to patients. Frankly, we really don't know what the knowledge needs are for patients. But our best guess at this point, I'm involved in a proposal to study this through the American Thoracic Society to find out what really basic needs are. Because we spend 8 hours with these patients about this. Oxygen therapy, why you're on it or why you're not on it. Because maybe oxygen would help. Oxygen doesn't necessarily always help patients exercise more. Shortness of breath, getting an understanding of that is a topic we talk about. We talk about relaxation or relaxation techniques. This is where I usually would have the social worker or the psychologist come in and talk to them about relaxation techniques. And patients, some gravitate to it, and some say, I have my own relaxation. I sit and fish by the pond, and that's relaxation to me. So whatever floats your boat, so to speak. And energy conservation. Now, this is really huge, because what you're trying to do is help patients do things with less breathlessness. And exercising them alone, they'll decrease their breathlessness with exercise or their dyspnea. But energy conservation, I've got to make my bed, how can I do it with less breathlessness? And if you've got airway obstruction, you want to push on the tough things. If you're going through a heavy door, you inhale first and then push as you exhale, kind of like weightlifters. They inhale and then exhale as they lift up. Same thing when we're teaching patients. If you have a restrictive disease, then all bets are off. A prolonged exhalation isn't useful for them. They're going to breathe faster to try because the respiratory rate is so quickly. So you're not going to teach them this prolonged exhalation, but you're going to teach them energy conserving things, like take a shower at a time of day when you have the most energy. Instead of taking a towel to dry yourself off, use a terry cloth bathrobe as your towel, and you just put it on and not worry about patting down so much. Some patients generate so much energy doing that, because showering is a very energy-consuming activity. And we often talk about advanced directives, because in real life, they need to know if, for some reason, they cannot speak for themselves, what would they like done for them? So there are ways to handle that. And this is what I've found in group. The other patients help so much in helping patients understand, hey, we're not talking about you dying next week. We're talking about you don't want your kids taking over your finances, making decisions for you. You might want, Joe here to be your power of attorney or your executive. He knows much more about you and so on. And then collaborative self-management. That's a buzzword now, is self-management. And nobody's quite sure the precise way to help patients integrate making decisions about their health. So the exacerbation of COPD, when patients start getting an infection, do they have the tools to start an antibiotic if that's indicated? Or do they know that they shouldn't try to grunt it out, but go seek health care? Sooner is better than later. So there are self-management. We talk about, okay, what do you do? What did your primary care tell you to do? And maybe you need to talk more about this and get a better, clearer plan. behavioral changes I mentioned is integrated, and it's so part of pulmonary rehabilitation, not only what we share with patients, but what the other people in the group share with patients. It's talking about self-management, support, monitoring them during exercise. We just don't put them on the treadmill, but we stand there with them, assure them their oxygen level's fine, their heart level's good. You can keep doing it. Can you keep doing it? Let's try just a minute more or 5 minutes more. And they finally feel comfortable and safe, and they extend their activity. And the empowerment that gives to them that they can actually exercise more is incredible. And then facilitating management of the disease. So you're exercising them on the treadmill, you see them cough, or you see them taking their inhaler many times. This is those teachable moments where you say, well, why are you taking your inhaler so much? And how many times a day do you really take it? And so you could guide them into the proper use of their medication. So the many teachable moments part of the program are indescribable. We measure a lot of outcomes, and fortunately we have, because this is what demonstrates, we know, decreases shortness of breath in patients, it decreases fatigue, it increases your exercise capacity, improves quality of life. All of these things we've measured and demonstrated. It decreases symptoms of depression and anxiety, which I'll talk about more. We have fewer hospitalizations. Actually, urgent care utilization or primary care actually goes up, but we feel that that's a reflection of seeking care earlier rather than later because hospitalizations go down. So what's the scientific rationale for all of this? It used to be, I remember a physician saying, that's all kind of hocus pocus, soft data, Sue. But it's not, because what we know now is that exercising not only helps the muscles, it helps desensitized dyspnea, called central chemoreceptive decrease. It helps with, I can't see well enough, but it helps the skeletal muscles. It helps the dyspnea in terms of you improving your exercise capacity. So it not only helps the muscles, and my good friends, physiotherapists who take muscle biopsies to show us that the muscles actually improve, and they do that over in Europe, not so much here in the States. But we have really good evidence from both the cellular as well as the gross exercise level that it does help muscles. So how about exercise training? Well, you start exercise training, and we know it decreases lactate production, which usually decreases exercise. But if you decrease lactate production, you can improve your exercise. More exercise decreases the ventilatory demand. You don't need as much oxygen in your body. Not necessarily to take it in, but you process oxygen more effectively, and it reduces your dyspnea on exertion. And this works for virtually any kind of respiratory disease. But furthermore, if you have patients with COPD, with maybe you've heard this, they have what's called dynamic hyperinflation, or which is the lungs tend to retain air as they exercise. They can't get as much air out each exhalation, and so they keep blowing up like a balloon, if you will. And dynamic meaning it happens with exercise. And what pulmonary rehabilitation does, it decreases the ventilatory demand, so their respiratory rate goes down. They exhale for a longer period of time, so they more efficiently get rid of that extra air in their lungs that developed from the exercise. So the less dynamic hyperinflation, they get reduced shortness of breath. And this is more focused on the obstructive pattern, and this is more generally, and this is what happens with emphysema. You get more of the hyperinflation in the lungs. Now, exercise can help. Bronchodilators help even more. A common long-acting bronchodilator is tiotropium, and this actually was a study by Dr. Casabury to show that tiotropium really helps exercise. But we've turned that one around on him and said, look at this. So patients start endurance time, and that's how long you go on a treadmill or a cycle in minutes. And you start patients on tiotropium or placebo, and on tiotropium they improve. But look how much they improve whether they're on drug or not with pulmonary rehabilitation. Their endurance times increased quite a lot in both cases, which tells us that, not that you're going to withhold medication from patients, but it says that exercise makes a difference, whether it's from tiotropium or whatever drug, where you can get a much higher response to exercise. So other outcomes are quality of life, and in the COPD area, St. George Respiratory Questionnaire is one that we use, the SGRQ, the Chronic Respiratory Disease Questionnaire, the CRQ, and the SF-36, which is the Medical Outcomes Study, short form 36. And it doesn't matter which one you use. And this is a chapter or an article that Dr. Puhan and I wrote, grading the quality of the evidence, whether it's shortness of breath measured by the Chronic Respiratory Disease Questionnaire or whatever, you get a high quality grade of evidence that dyspnea, fatigue, and quality of life improve. There's just no question about it. Depression, on the other hand, if you look at the data, you'll see that we have a low quality of evidence. And the reason for that is that people use various measurement instruments to evaluate depression. And so it's hard to compare both. So the quality of evidence cannot be the same. It can't be rated high because of that. And there's also patients aren't enrolled because of their depression. They're enrolled because they're short of breath and have limitations in their activity. And so there's also a bias there, which causes us to grade it low. But I'm going to show you something about depression that's really, really interesting in pulmonary rehabilitation that came out a couple of years ago. First of all, if you look at a meta-analysis, and this is when you take all the studies that are comparable and you look to see whether it favors pulmonary rehabilitation, which means it's on the left-hand side, or it's on the right-hand side, it does not favor. You see, it's a reasonable thing to say, so pulmonary rehabilitation improves depression. But as I said, it's low-quality evidence because one person might use the Hospital Anxiety Depression Index, another might use the Beck Depression Index, and it's depression. We're only talking about symptoms of depression. We're not talking about a diagnosis of depression. However, Harrison and her group looked at over 500 patients had gone through their rehab program. They all had the HADS, Hospital Anxiety Depression Scale questionnaire, and there were 315 where they had pre-post data. Their program was 7 weeks in length. And we see that they had a significant improvement in the scores, but the minimally important difference, minimal clinically important difference, the difference that should make a difference, was not reached because it only changed 1.06, and it'd have to change 1.50 to really be a clinically significant difference. But what they did is they said, okay, let's look at our groups, and I think this is a good lesson for us to learn about any of our outcomes. They looked and they found out that about, what's down here, 61% of patients didn't have depressive symptoms. That's a huge number. 22 had probable high risk of depressive or a diagnosis of depression, and 17 had a high likelihood of the presence of depression. The HADS, they have been looked at correlations and found what the chances of them being significantly depressed are. And so when you look at the group who are not depressed, clearly they don't improve with pulmonary rehabilitation. In the group who have probable depression, they did improve significantly and met the minimally important difference. And then you see the group with severe, they changed by 3.19 points, which was twice the minimally important difference. So in measuring outcomes, what we learned from this is don't lump them all together, because then you get a lumped sum mean of what's going on. But if you look at people who actually have the problem, the significant depression, you can see we got a huge effect from pulmonary rehabilitation. And this is a standard program. In terms of healthcare utilization, Griffiths published this, and we still use it because it keeps getting replicated over and over again. You see a decrease in all-cause hospital admissions, a decrease in hospital admissions due to respiratory disease, and an increase in hospital primary care visits, which I mentioned earlier, is often a reflection of patients seeking care earlier appropriately, because you did see a reduction in their hospitalizations. So what about the non-COPD patients? Because this is all based primarily on COPD. Well, we're seeing more and more work with ILD, interstitial lung disease, which can happen with coal miners. Pulmonary hypertension, which I hope doesn't happen much with coal miners, because it's a very different ball of wax, and actually I think only specialized centers ought to work with those people. These are the people who are probably going to get lung transplants. But we've seen rehab in neuromuscular disease, beginning to see more patients with obesity, so we're modifying our programs. But coal miners have problems with weight as well. We do it to help get patients in shape before surgery. Asthma, bronchiectasis, cystic fibrosis. They were doing it in lung cancer to improve their quality of life, get them back. Lung transplant centers, many require rehabilitation before and after, and then some with chest wall disease. But I think the pertinent groups here are the interstitial lung disease and the obesity, in addition to the COPD. So why might this help these groups of patients? Why not coal miners? Because they all have a ventilatory impairment, in other words, impairment in their lung to be able to breathe. And ventilatory impairment leads to exercise impairment, symptoms, and impaired quality of life for a variety of reasons. They're probably not one, but they all contribute. Skeletal muscle dysfunction being one, but the symptoms prevent them from exercising, affect their quality of life. Exacerbations get thrown into the mix. So there's no reason that it cannot work for people without COPD. So what are the exercises I mentioned earlier? Typically, exercise training, and I mentioned that brief interval training where they exercise very aggressively for a short period of time, maybe a few minutes, and then they take a 10-minute break. And you can still get improvements with that. But there are other options, such as water-based training. Some people use the pool, especially for people with hip dysplasias, knee problems, and you see this in the patients who are overweight. Water-based training can be helpful, so getting them in a pool for exercising. Tai Chi can not only be relaxing, but it also can help those with flexibility. So there are some people that find that Tai Chi is helpful. Some programs try to integrate that. The data is not quite as strong with this group because there are not as many people that have been studied in a systematic way. But we do understand that everybody is different. And this slide shows that. If you look at 3 different patients, you might find some that need a little bit of everything we do in rehab. Talk about their oxygen, talk about their medication, the bronchodilators, give them exercise training, and talk about self-management strategies. But then you might have some patients that come in and they have frequent exacerbations and they need more focus on self-management. It's not that they don't need some exercise training and so on, but they really need to prevent future exacerbations. And being instructed and guided how to manage it can help reduce the amount of time the exacerbation happens, and hopefully abort it altogether, but at least reduce the severity of the exacerbation. And then there are those who are just so deconditioned, that they need really heavily long exercise training. It might start with referring them to a physical therapist to get balance, strength, so that they can stand with some confidence, and then put them through a program. So no 2 people are alike in rehab, and that's why we tailor it to what the needs are of the patients. So let's talk about a little bit about the future for rural areas. And to do this, I looked at the literature for telehealth, also known as telemedicine or telerehabilitation. Nobody has a corner on the market on telehealth. There's some promise, but we're not about to say that this is the end-all. But I think it's complementary to what one can offer in a community. This is a study by Sticklin in Canada. And they looked at patients in a standard outpatient setting and received pulmonary rehabilitation versus telerehabilitation. Patients self-selected for this group. So these probably were people who were sicker, didn't want to go to the hospital, they wanted to do it in their own community. They had 147 who wanted to do the telehealth that were assigned there, and 262 to the standard pulmonary rehabilitation in the hospital. They were both for 8 weeks, 2 days a week. 2-hour group exercise, an hour of education, which happened by video conferencing. And the exercise consisted of walking, cycling, arm ergometry, as I mentioned earlier, and flexibility training. The telehealth group, as I said, they did the education via video conference, and they were trained locally by someone locally. And the thing is that the groups in the telehealth had smaller groups, so you didn't get as much input from your peers, but they got input nonetheless. And these were held at a local community hospital. The outcomes that were measured were health-related quality of life and exercise. Now, we usually think of exercise capacity as a 6-minute walk distance or the shuttle walk distance. This was, the 12-minute walk was the older version, and they probably didn't want to change their outcome measure midstream, and so kept it. And what this showed is that both groups improved on health-related quality of life, and the walking distance improved in both groups. However, the telehealth group, they began with a lower quality of life and lower a 12-minute walk than the standard. And so it probably would have been a better effect. But like I said, they self-selected. So they might have been a little bit sicker, but they improved nonetheless, which says telehealth is feasible in a community setting with local support. Video conferencing for education to complement the program. It can be very useful and productive. The next one I want to mention is one by Tabak that was recently published on telerehabilitation, and this was a proof of concept study or randomized pilot trial, and they used telerehab versus usual care, and they had a small number, 14 telerehab, 16 usual care. They exercised for 4 weeks, and they had an activity coach in the telerehab where they had an accelerometer and smartphone, and they had communication, and they had feedback. Now, this is kind of sophisticated, and it's been useful in other conditions, reminders to people on insulin or to HIV patients to take their medication. So this was an attempt to combine some technology. They also had real-time feedback, a web portal to report their symptoms and their exercise and what they did if they had exacerbations. They looked at health status, and this time with a clinical COPD questionnaire, and activity levels were measured with the pedometer. And they found that actually there was no improvement in quality of life or activity between groups. However, the health status actually improved for the individuals in the telehealth group. So there was no difference in the improvement between groups, but in the telerehab group, they did improve. So it's showing that there might be some promise in that regard. So my take on this is, and from what others have said regarding telemedicine, is the benefits. It's feasible to do telehealth, telerehab. It's patients who are properly trained find it easy to use, but as you all know, with technology, even me, it has to be easy to use, and it increases access. More patients can get pulmonary rehab. The challenges is the cost or access to technology, that not every facility has that. Depends on the technical competence of the patient. So you have to have someone who is, so you really need to modify for what your community is like, whether they're technologically competent or not, or capable, and have the resources. There is a potential for service disruption. So if you're doing a video conference, you've got a plan that you might lose some connection, depending on where you are, and you would know what your capabilities are. The experience we have overall training with telehealth is kind of limited. So it's new territory for everyone. So it's an opportunity for those who are saying, we want to offer our group what you can get in the urban communities. This is the opportunity. The other challenge I find is outcomes data. To be able to say that you improve, you have to measure outcomes. And it requires patience and time, making sure patients get the questionnaire before and after the rehab program and at some point afterward. So these are kind of the challenges, but they're not insurmountable. And I've put two references down here, exploring telemonitoring and self-management by patients with COPD, in patient education counseling in 2013, and home telemonitoring by Cruz in the International Journal of Medical Informatics this past year, a systematic review of methodologies and patient preferences, which tell you about some of the challenges of that. So what can you do in the rural setting? Well, there's a lack of data. However, the options, I think, with telehealth are evolving pretty quickly. But you have to identify who your team players are in your community and partner with them. It was surprising to me when I went to New Mexico. It was a physical therapist that was all jazzed and a respiratory therapist that was all jazzed. And that was the basis for my team there. In Loma Linda, California, everybody wanted to be involved, and we got OT involved, PT involved, the psychologists involved, and it was a much more, how should I say, plush resources that I had available made the time to do it. So you have to make the time, but you have to make the connections, and you find out who your strong people are. And don't underestimate volunteers or former rehabilitation patients who can come and help. Check the patient in, give them the questionnaires for you, things like that. We've done all of that. Partnering with the local health clubs, I think, can be a great potential as well. Whether it's Gold's Gym or your local gym, whatever they call themselves. But I think the barrier that I found with them is they're not very confident that they can take a COPD patient or a patient on oxygen. They're very concerned about that. And so it requires reassurance by the healthcare provider that, yes, indeed, the patient can exercise and be supervised, and it might be helpful to have a physical therapist or respiratory therapist help guide them initially so that I did that in New Mexico, and a lot of patients would sign up afterward for maintenance because they say, hey, don't worry about me, I'm fine, I'm safe, I've already gone through rehab. So, it's possible to do that, but it requires confidence on the part of the patient, which you can do that on a one-to-one, and confidence on the part of the gym. But that is also an option. And then the video conferencing. There are all kinds of things that I haven't even thought of, and I'm sure others have had more experience with in other arenas that you could integrate. So what are the other settings? There's the fitness center, as I mentioned, community-based. These have been studied. They usually are 8 to 12 weeks. There's not the number of disciplines involved. It's good for stable patients that need only exercise. And then, of course, in the nursing home, the physical therapist and the physical therapy assistant can help with exercise in the nursing home to get the patient strong enough to go home, hopefully. Primary care settings, there's also limited practice there, and it's usually been in the physical therapy practice where they get referred a patient. But there is some question about, well, if you only see one person, is it really comprehensive rehabilitation? Because it really takes a village and all of this to meet all of the patient's needs. Physical therapists could recognize one thing, but they might not understand the oxygen needs like a respiratory therapist or a nurse would. There's the home, and in Europe, they do a lot of home rehabilitation, and they think that's equally good. Again, the resources are limited, but they generally send in 2 people, and people get to stay in their home. And it's great if they have poor mobility, but if they're independent, I think there are other ways to get around that. And then there's the home telemonitoring for guidance that I pretty much just mentioned, which might be good for maintenance or for your primary rehabilitation. Now, okay, so you don't have rehab going. She didn't tell me anything about what I can do with my patients now. And so here's my exercise prescription to get patients going. First of all, establish that they can stand without assistance. And I say, if you can stand out of your wheelchair for 5 minutes, you're good to go. We can work with you. Otherwise, they need a physical therapist to help them with stability exercises so that they can do this as safety. Establish what their current ability is to walk. So how far can you walk? Walk in the hall for me. So they stop in 2 minutes, and then they rest, and then they walk 2 more minutes. Okay, so our goal for you is going to be 3 minutes nonstop walking. I want you to practice this for the next 2 weeks, 5 days a week. I don't care what day you do it, 5 days a week, so that you increase them, and they'll increase their confidence. And I'll show you some assistive devices. It's not a bad thing for them to use. In fact, it's a very helpful thing. So you build them to 3 times a week, followed by 5 times a week. The intensity increase, I usually do it every 2 weeks, depending on how impaired they are. If someone says, I can walk 10 minutes nonstop, say, great, I want you walking 15 minutes nonstop in 2 weeks. When I call you, you call my nurse, or you come to the clinic, or whatever. So you do it in increments to develop their confidence. And follow up with some kind of phone contact. Either have them call in and say what their distance is or their time is, so you can at least provide that positive reinforcement. Here are some of the assistive devices. Rollators are great because they can put their oxygen tank in there, and the women can put their purses or whatever. And it's good for confidence, and it's a place to sit down as well if they get tired. And it's not a problem if they have to sit down and catch their breath. The important thing is they get up and they move. Energy conservation techniques. Occupational therapists are great at showing that. Again, if you have a patient with severe obstructive disease, you might be talking about prolonged exhalation versus a patient with restrictive disease who breathes rapidly. You're not going to be emphasizing pursed-lip breathing to this group because that's to prolong the exhalation. So you can do various breathing techniques or energy conservation, the bath towel or bathrobe technique. Financial coverage, this is my only slide because unless you really want Medicare or insurance to cover, insurance usually go with Medicare. With COPD, they say it has to be moderate to very severe, and that's where you get into the spirometry, so they can say the FEV1 is less than 50%. They will take in mild COPD, and we've got good evidence that they should because they get equal benefit. In fact, people with mild COPD have changes in their muscle strength. And you can appeal for mild COPD and respiratory conditions. And if you have a good relationship with your insurance company, you can often get them changed. There is, with the Medicare, a 36 sessions that you're allowed. And this is a paper nightmare with Medicare, from what I understand. I worked in the VA, so fortunately I didn't have to deal with that. But it does require attention to paperwork, as with any Medicare thing, because they want to see that you're making a difference in these people. So you have to measure outcomes, have your goals set. So in summary, I don't know how I'm doing here on time, but maybe, I'm doing really good. Pulmonary rehabilitation, it's very clear. It improves symptoms, quality of life, and exercise in patients with respiratory disease, not only COPD. It's not limited to a diagnosis of COPD, although much of the older literature will say they have to have moderate to severe COPD. It has been demonstrated as very useful in those with mild. Rural setting creates a challenge, but I know rural people are very resourceful. They're very hardy. They're going to find a way. They want to be in good shape. And so you've got really the elements that you often might not see in an urban setting where things are a lot more comfortable for them. So maximize their resourcefulness and consider what are the other options to complement your program to make yourself a program in a rural setting. Because I really think this is a really good fit in the rural setting to have pulmonary rehabilitation. And then you'll be the first in your neighborhood. So thank you very much. Appreciate it. Any questions? Dr. Sood?
This was a fantastic talk. Late in the day, but really fantastic. So Sue, for home tele-rehab, what data exists? That was my first question. My second question for tele-rehab in general, is anything payable by the...
Only the pilot study There might be another one out there, but it wasn't as significant as this one. So it's all proof of concept right now, trying to integrate, because we've spent so much time trying to offer it in community, in urban settings, that we realize this is not where people live. They live in rural settings, so we need to find alternatives. So we were kind of short-sighted in that. So the data is very, very limited. And I think like rehabilitation itself, it's going to be what are the needs of the people in the rural community and how can we adapt best to that.
And any way of getting it paid for by the insurance?
Insurance companies and Medicare, but it does require documentation. It will require a medical director, so it would be finding a physician in the community who would be willing to be the medical director, which often case, like as you know, with in Albuquerque, she does all the paperwork and just says, this is what I'm planning on doing. What do you think? These are the risks.
I'm sorry, tele-rehab.
Oh, tele-rehab. I do not know the answer to the question. It's a good question. That's an interesting question, because the tele-rehab has been done outside of this country. They haven't had to deal with that. So that question has never come up. Good question. Thank you. Yes?
This was my favorite part of this whole entire conference. Pulmonary rehab is just my passion, and so I'm so glad that you came to speak to us on it. I did want to just mention that in the past year, several programs have been set up in very, very, very rural West Virginia. Most of our miners do not live in cities, obviously, and they're set up in FQHCs, very small primary care clinics. We're having excellent results.
Is that the one Ted Koppel's wife funded?
Yes.
I read about that, yes.
So
you're very fortunate.
Yes, it is absolutely, I think, for several of us, our dream job.
Yeah.
But they are talking about doing others. And so if there's a community that has, somebody who's passionate about it, I think there are people that want to bring pulmonary rehab to rural areas. So
I think we want to talk to you.
Okay. But so telemedicine's a great thing. I think there are some other options as well.
Have you tried the telemedicine route to help complement your own?
I haven't. I think that our patients live right there in that little community, and there are so many of them, and they like coming and they like seeing their buddies and people they worked with in the coal mines. And I think that if someone were very geographically isolated,
I was thinking for the education component only at this point is building from that and video conferencing. So you use somebody else's resources that is, the presenting of the content. They've already got it, narrowed down, and so you can use your resources for exercise and such.
Yeah, I think we bring them in a couple times a week, and they're already there anyhow, and we do the education after, so it works well for us.
Great.
Anyway.
I would like to communicate with you.
Okay, thank you so much.
Thank you.
What an awesome presentation.
Thank you.
I just kind of want to, not really a question, I'm also part of the Ted Koppel with her in a different location.
Congratulations
in West Virginia.
on that. That's
Thank you.
Super.
We talk often about rehabilitation and COPD, but we all are here for our coal miners. And one of the things that I found that has been really rewarding, my first 12 graduates were all retired coal miners. And we was able to get either the Department of Labor or their state compensation to pay for 32 sessions of rehab. And they're also paying for their maintenance programs now.
Fabulous.
They're reimbursing their travel and everything. So I just wanted to get that out there to take back to your clinics that if you have a miner that needs rehab, comp and federal Department of Labor is paying for it. It just, state comp usually requires you to bill, of course, your spirometry and, a request for the rehabilitation. We've noticed like HealthSmart is really paying a lot for the miners. HealthSmart is actually the first one that they contacted one of their patients and said, we hear you're taking pulmonary rehab. How's that going for you? And he told him, she got me to quit smoking. After 4 sessions, I could breathe. After 4 sessions, we physically noticed rosy cheeks again. And you're talking about 4 weeks. Well, we noticed it in 2 weeks, a difference in his circulation. So it was very exciting and rewarding, and that they contacted him, and then they contacted our clinic and said, how many miners do you have that have this insurance? And they say, we're willing to pay for them. This is a lifetime commitment. It is not just, 32 sessions. These minors need this for a lifetime. We're willing to pay for them to get there, their mileage. We want to pay for their sessions. And like in our clinic, for instance, our maintenance program, a session is $5. So they're more than willing to pay $10 a week for this minor to continue to exercise. So, it saves them cost. It helps, with their medical bills. And like you already discussed, it helps with decreased hospitalization. So, it's helping in the rural areas. And, our 1 year of being open has been, life-changing for these minors.
Thank you so much,
You're welcome.
both of you, for sharing that. That's really important information. Yes?
Last question, Linda. All right, Susan, really, really great, talk today. One of my questions is because it's out there from the legal side and certification. They're looking at there has to be a direct supervisor on site. Now, this can greatly affect many of the rural areas. What have you seen? Okay,
so the medical director does not have to be on site. It says a medical director has to be available, that they do not have to, like cardiac, I think they have to have a cardiologist around. It's much stricter with cardiac than it is with pulmonary.
And my understanding is pulmonary they're looking at also with this.
About having on-site
legislation, yes, for critical access hospitals specifically.
Okay,
and many in rural areas have that.
Yeah, the thing that would speak against that would be the need for that is pulmonary rehabilitation has been shown to be very safe.
Right.
I don't know of any deaths. There have been studies that have reported the safety, no safety issues at all. There's been concern about the 6-minute walk in other studies not related to pulmonary rehab, that it's unsafe. Any problems have been absolutely minimal. So it's just one of those hoops that someone's trying to get people to run through.
Right.
And so I would be so disappointed if they required somebody
That's
else.
Perfect. I think we need to get that data to the Hospital Association then. That'll
Yeah.
help. Okay.
Thank you.
No.
Any doctor, yes.
But they're staying on site. So,
They're hospital-based then, huh? Or community-based hospital? Yeah. Great. Thank you. Thank you so much.
Thank you.